हेलो दोस्तों, आज हम बात करने जा रहे हैं हाइपरटेंशन इन प्रेगनेंसी के बारे में। सो व्हाट इज़ हाइपरटेंशन इन प्रेगनेंसी? इट इज़ ग्रेटर दैन 140/90 mm of Hg 2 times at a 4-hour intervals apart. So this hypertension in pregnancy is divided into two things, which is chronic hypertension in pregnancy and pregnancy induced hypertension. So what is chronic hypertension in pregnancy? It is a hypertensive female who has conceived. So this pregnant woman will have hypertension from the first day of her pregnancy. So now coming to pregnancy induced hypertension. This comes because of placental pathology after 20 weeks of gestation. So now this pregnancy induced hypertension is divided into preeclampsia and gestational hypertension. So what is gestational hypertension? It is the only increase in BP. Then what is preeclampsia? It is increase in BP with proteinuria. Now this preeclampsia is classified into mild preeclampsia and severe preeclampsia. What is mild preeclampsia? It is no signs of end organ damage or no symptoms of impending eclampsia. Now coming to severe preeclampsia, it is end organ damage plus signs of impending eclampsia. What are the signs of impending eclampsia? These are epigastric pain, headache, visual disturbances. Now this severe preeclampsia may complicate into eclampsia or HELP syndrome. What is eclampsia? Eclampsia is increased BP plus proteinuria plus seizures. Now, what is HELP syndrome? HELP syndrome stands for H stands for hemolysis, EL stands for elevated liver enzymes, LP stands for low platelet count, which is less than 1 lakh per millimeter cube. Now coming to the pathology of pregnancy induced hypertension. So basically there is problem in the placenta in pregnancy induced hypertension, which is incomplete trophoblastic invasion of uterine arteries. So because of this, the high resistance uterine arteries do not get converted into low resistance uterine arteries. So because of this, there will be less blood in the intervillous space and less supply to the fetus. Now this incomplete trophoblastic invasion, it leads to insufficient uteroplacental circulation, which leads to placental ischemia. Now this placental ischemia leads to reduced size of placenta. This placental ischemia brings changes in the mother blood, which is it increases the vasoconstrictors in mother blood and decreases the vasodilators in her blood. So this increase in vasoconstrictors leads to the increased BP and also endothelial damage. This endothelial damage will lead to leakage of blood, which will lead to pathological edema. Now this endothelial damage, it leads to the cerebral edema, and this cerebral edema will lead to cerebral hypoxia. This hypoxia triggers the release of excitatory neurotransmitters, which leads to eclampsia. Now this leakage of blood will lead to concentration of blood in the blood vessels. This will lead to stasis of blood and platelet aggregation. So now because of platelet aggregation, there will be decreased platelet count. Now this stasis of blood and platelet aggregation leads to the thrombus formation, and this thrombus gets circulated over the body and leads to a multi-organ failure. One of the example of multi-organ failure is the kidney, which decreases the kidney filtering capacity. This results in increased serum concentration of greater than 1.1. Now, because of decreased placental circulation, there is decreased blood supply to the fetus, which results in intrauterine growth retardation and decreased renal blood flow. So because of decreased renal blood flow, there is decreased urine and there is oligohydramnios. Now, what is the definitive treatment of pregnancy induced hypertension? It is just terminating the pregnancy and removing the placenta. As soon as the placenta is removed, the blood pressure comes down back to the normal. So now coming to the drugs which are used in pregnancy induced hypertension are antihypertensive drugs, which are labetalol, nifedipine and hydralazine. Then first dose of corticosteroids is given first, and then if no severe preeclampsia, eclampsia, fetal distress, HELP syndrome are present, then the pregnancy is continued and the full course of corticosteroids is completed, and then the pregnancy is terminated after 34 weeks. The anticonvulsive therapy used in pregnancy induced hypertension is MgSO4, which is magnesium sulfate. It is a neuroprotective agent and membrane stabilizer. Now, MgSO4 has two important regimes, which is Pritchard's regime and Zaspan regime. In the Pritchard's regime, loading dose is 4 grams of 20% MgSO4 IV, which is given in 3 to 5 minutes, and 10 grams of 50% MgSO4, 5 grams in each buttock intramuscularly. So the maintenance dose in Pritchard's regimen is 5 grams of 50% MgSO4 IM. Now, what is Zaspan regime? It is a loading dose of 4 to 6 grams of IV slow over 20 minutes and a maintenance dose of 1 to 2 gram per hour IV infusion. So now we move on to the summary. So what is the summary? Summary is in pregnancy induced hypertension, there is problem with the placenta. So ultimately, if the placenta is removed, the pregnant woman will blood pressure will come back to the normal, and the complications of pregnancy induced hypertension will get reduced. So this is the story of hypertension in pregnancy. Thank you.